All right. Good evening to our Facebook and YouTube Spark Roundtable Series. Welcome to our Spark Roundtable Digital Roundtable Series, Eliminating Bias in Healthcare. My name is Tammy Charles, and I am the founder and the managing director of Tampa Bay Spark. We've been around since 2018, hosting important conversations just like this. So very, very excited to be here tonight with you all. So for the past couple of months, our focus has been on health. We recognize that in order to create a leveled playing field in technology and entrepreneurship, it is critical for us to discuss the health disparities that continue to plague communities of color. So tonight's event represents our final installment on overall health as we enter into our next series on economic justice. I'll talk more about that later on in our presentation. So why are we here? We're here because Black and Latinos were 4 to 9 times more likely to be infected by COVID-19 than whites. Structural racism, discrimination, and the negative impact of the social determinants of health, including lower socioeconomic status, less access to education, and hazardous environments, and so many other factors continuously undermine the health and well-being of minority communities. This is compounded by having less access to healthcare, and when they're able to see a healthcare provider, often engaging with significant mistrust or language barriers that makes it very difficult to obtain high healthcare. So what can we do? Our panelists are going to be talking about that tonight. So Tampa Bay Spark, our mission at Tampa Bay Spark is to equip and train business and community professionals to co-create and implement strategies and solutions that will lead to economic justice, equality, and inclusion for the communities and companies that we serve and lead. Spark Digital Roundtable Series is designed to create an intentional space for us to have these important conversations, y'all. They're meant to be courageous. They're meant to educate, inspire, and equip purpose-driven, conscious leaders just like all of us to implement authentic justice and equitable practices within our spheres of influence. And we are so excited to have this conversation tonight. So you can learn more about Tampa Bay Spark at www.tampabayspark.com. Follow us on social media, Facebook, Twitter, LinkedIn, and Instagram to be updated on our upcoming events and resources. Now, the work that we do, I don't do it alone. I have an incredibly brilliant team who is constantly just pushing us forward, creating such amazing content. So I want to give a shout out first and foremost to Erica Braham, who's actually our moderator tonight. Woot woot, so excited for her to moderate this amazing conversation. She is a prodigy. She is a young woman who is killing the game. So honored to know her. She is an equity operations manager at the Tampa Bay Healthcare Collaborative, but she's also the VP of Speaker Relations at Tampa Bay Spark. Jessica Vega Eugene is the Strategic Communication Specialist at Vistor Communications. Bess Georges is the e-learning specialist. She's also a 6th grade math teacher. Big up to Bess. Monique McLeod is the CEO of the Management Suite. And we also have Alicia Henson, who's the annual gift specialist at Gulfside Hospice and Pasco Palliative Care. So if you all can give a virtual round of applause to our incredible team who is doing such incredible work, I'm so honored to work with them. Now, let's get this thing started. I'm going to go ahead and introduce our incredible moderator and our amazing speakers. I just can't say it enough. We are honored for them to join us tonight. So first and foremost, again, want to say a little bit more about Erica Braham, who's a part of the Tampa Bay Spark team, but who's also moderating this important conversation. Erica serves as the Equity Operations Manager at the Tampa Bay Healthcare Collaborative, which is an organization that fosters community collaborations for helping the underserved. She brings amazing skills of leadership, community development, and education and research and program planning to oversee the daily operations of several of the collaboratives program. She's also the VP of Speaker Relations at Tampa Bay Spark. So let's give a round of applause for Erica Braham. Thank you so much for joining us tonight. Kimberly Williams serves as in the role of the Director of Community Benefit for Advent Health West Florida Division, where she works collaboratively collaboratively with internal hospital teams and external community leaders to strengthen the whole health of communities by responding to identified community needs with initiatives that address key social determinants of health. We're so honored to have Kimberly Williams join us tonight. Nicole Williams is a board certified family nurse practitioner who practices within a local internal medicine clinic. She manages a myriad of complex chronic illnesses and leads a high-risk case management program mitigating hospital readmission rates for Medicare managed care clients. We're excited to have and honored to have Nicole Williams join us tonight. Jennifer Yeagley is the CEO for the St. Petersburg Free Clinic. She actually just, I think you're on your first year anniversary. She joined the organization in March of 2020. Woo woo. She has presented in forums around the nation on diversity and cultural competence, including the National Association for African American Studies, Mid-Atlantic Women's Studies Association, and the Florida Philanthropic Network. We're honored to have you tonight, Ms. Jenna Yeagley. Eric C. Smith is currently the managing member of Inclusivity LLC, an organizational development and marketing advisory firm with offices now based in Florida, specializing in cultural competence, community relations, and cross-cultural marketing for both for-profit and non-profit enterprises. Excited to have your perspective tonight, especially in this corporate ecosystem space. Last but certainly not least, we have Dr. Marquita Wills. She is a board certified psychiatrist with a master's in business administration from the Wharton School of Business. She currently serves as a chief medical officer of Johns Hopkins Healthcare. She possesses a valuable combination of skills, sharp analytical business acumen, coupled with a natural ability to build impactful, transformative relationships with others. So if we can give just a virtual round of applause for this expert panelist, we're so honored and excited to have you all here tonight. So I'm gonna just pass it on to my dear co-worker, co-leader in this process, and our amazing moderator, Erica Braham. Before I do that though, we wanna hear from you. So if you can share, I think I have a question that I'll post it, is have you ever faced bias in your patient experience? And how did this experience make you feel? So if you can share in the chat below, we would love to hear from you tonight about your thoughts and what you're processing. All right, I'm gonna pass the mic over to Erica Braham. Thank you so much.
Thank you, Tammy, for that wonderful introduction. We are so excited to get this conversation started. So that being said, as the audience as well, please engage with us. Feel free to drop your questions in the chat and we'll get this going. So to really begin talking about the future of eliminating bias in healthcare, we have to revisit the past. Some people from racial and ethnic minority groups may hesitate to seek care because they distrust the government and healthcare systems responsible for inequities in treatment. We talk about this with historical events such as the Tuskegee study of untreated syphilis in the African American male and sterilization without people's permission. So what are some other historical contributions to the disparities, biases, racism, and discrimination in healthcare that we see today? And I wanted to point this question starting off with Eric.
So thank you a lot, Erica. I really appreciate the time to be here, and thank you, Tampa Bay Spark, for allowing us to have this great conversation. But actually, I want to dial it back a little bit, because when we start to talk about these conversations, the first thing that pops up is the Tuskegee Experiment. It's like when we start talking about civil rights, you start talking about the Civil Rights Act of 1965. So the Civil Rights Act, the first one was actually 1865. That was vetoed, and then the actual one that actually ended up on the books was 1866. But here's the part of it that's disturbing, extraordinarily disturbing, is that when we start to look at where does this come from for the African American community in terms of experimentation, it actually happened in the early 1800s with a doctor called J. Marion Sims, that they actually had a statue erected that was sitting in Central Park for almost 8 decades before they took it down, realizing his story. And there's some information that'll be shared with you in terms of a video that talks about it, as well as a Washington Post article. And the point of it is that he did over 80 different surgeries on female slaves with no anesthesia. Let me just say this again. Surgery with no anesthesia. And 30 of these surgeries was on this one woman named Anarcha. 30 surgeries, which means you're being cut open, 30 surgeries. So the thing about it that makes it that much more powerful is that some of the things that happen in terms of, well, Black women can sustain more pain. They may not need the kind of different types of medicines in order to eliminate pain because they can handle more pain. Where does this come from? So there's reasons why some of the things that we take as normalcy or even the disparities that we see, there are always historical derivations that are associated with it.
Thank you for that. And with that, Dr. Wills, I just wanted to point another question in your direction based off of this talk of medicine and treatment and mistreatment. How has medicine been used to weaponize and misdiagnose patients? And what's the root cause of that? Going back to Eric's question. Oops, you're on mute still.
Thank you so much for that question. Happy to be here with everyone this evening. Eric brought up a lot of really great points. I'd like to build on those at my own institution, Johns Hopkins Healthcare, where we talk about Henrietta Lacks. I'm not sure if people are familiar with Henrietta Lacks, but she was an African-American woman who went to the Johns Hopkins Hospital and had cervical cancer. Turns out they extracted her cells and they were able to grow. And they were able to grow in a very important way. And they never told her that they took her cells. Her family has never received any compensation for having her cells having been taken, but her cells have duplicated and been a big part of medical science because they had a unique feature and that they replicated every 20 to 24 hours. So there are all these experimental things that have been done to African Americans. And then in my field, the field of, oh, by the way, Johns Hopkins is planning on honoring Henrietta Lacks and her family by naming a building after her in recognition of in the 1950s situation against her and her cells. Another example is in my field, the field of psychiatry. Back in 1851, an American physician named Samuel Cartwright hypothesized that slaves fled because they had a psychiatric condition. That psychiatric condition was entitled drapetomania, D-R-A-P-E-T-O-M-A-N-I-A. So we were actually diagnosed with a psychiatric illness because we wanted our freedom. And interesting, it wasn't until 2021, earlier this year, after everything that happened last year in regards to COVID and social injustice, et cetera, that the American Psychiatric Association actually issued an apology to Black, Indigenous, and people of color, BIPOC folks for its support of structural racism in psychiatry with things such as this atrocity. So in many ways, medicine has been used to really define and describe features of our communities as pathological that weren't necessarily so. So just knowing these stories and these stories having been transmitted from generation to generation causes what I would say is a healthy skepticism, right, of the healthcare system in communities of color. And so that's just something that I think we always need to go back to our history. So thanks so much for asking that question.
Yes, thank you. And so, Kimberly, can you tell us from a public health perspective how this same systemic racism and systems have kind of put communities of color at risk for negative health outcomes?
Thank you so much for that question and the opportunity to kind of bring in that public health piece that's just so super essential. I think we need to really start with having a clear understanding or a clear definition of what systemic racism is, and I'll be as brief as I can on that. So when you think of systemic racism, it's essentially policies and practices that exist throughout our entire society or organizations, and it's these policies and practices that really result in this continued unfair advantage, right, of some people, and then this unfair or harmful treatment of others, and it's based solely on race. So we have to first kind of look at the foundations of kind of what we're talking about when it comes to systemic racism, and then make that connection to the communities of color. And you'll sometimes hear systemic racism referred to as like this institutional racism, that it's kind of embedded in our institutions. It's a normal practice, right? It's just the way we do life, or it's intentional, or it's unintentional. There's so many different things that you'll hear, and I'm sure now we've heard so many with just the place that we are in our world today. But we have to look at how systemic racism is in every part of every institution. It's such an impactful piece to this connection of health outcomes, health disparities, social determinants of health. And essentially, when we think of those systems, it's our educational systems, it's our healthcare systems, especially because, we're focusing on that today. But it's also our judicial systems, our criminal justice systems, and it's really all of the institutions that make up the way we live today, the structure of our society. It's how we make our decisions, right? It's how we decide what's just and what's fair. But all of that leads to discrimination that really impacts people of color, because remember, we talked about it being based on race. And so just with that, really it's the driving force of what we call social determinants of health. And those are like those barriers, to achieving this optimal or best health. And it's significantly impacting our communities of color. I can't appreciate the fact that the American Medical Association and the American Public Health Association have now recognized racism as a serious threat to public health. It's a public health crisis. So, we know that it's been there, but it's now recognized. And so that moves us into doing more about it, right? Acknowledging it. But essentially, when we think about this impact that it has on our communities of color, this negative health outcome impact, when we talk in terms of social determinants of health, these are, the way we access healthy foods, our safe communities, our neighborhood safety, our, sustainable housing, income levels, quality of education, availability of transportation. It's not just like a one bucket thing, it's all of these things that pour into whether or not our communities are successful in their health and their health outcomes. And so when we say the driving force of, the social determinants of health, which really connect us to good health, optimal health, if we say that driving force is, this systemic racism, that's a huge problem. And just to chime in on what the other speakers have mentioned, it's rooted in what the history that has taken place with the treatment of African American individuals in the health system in our community. So I think that we could definitely take deeper dives into the impact of this, but I think what we have to see is that this negatively impacts, even today. We're going from history up to today, but it still has a mark on those outcomes in our communities. So I look forward to talking more about that. I could definitely talk more about it. I know we have opportunities to share how that impact is still hurting us today, and how we are looking for solutions to solving this together. So thank you.
Thank you for that awesome perspective, Kimberly. And with that, that's a perfect lead into the next question, which is also going to be directed towards Nicole. As we talk about this, the social determinants of health, we want to know, and bringing the conversation back to COVID today, we know that minority communities and communities of color are experiencing much higher rates of infection and hospitalization from COVID-19 than their white counterparts. And now that we have a vaccine, we're actually seeing that more of these communities are receiving their vaccinations at much lower rates than whites as well. Can you explain some of these specific current social determinants of health that might be driving this for the COVID pandemic?
Yes, Erica, thank you again for inviting me to speak on this panel. I really appreciate it. So the biggest thing is, with COVID, more of our people of color were affected at much worst rate of infection, including complication and death. So then you have, now that we have the vaccines, how many of them trust the vaccine? So we go back to Eric's understanding that there is still a big amount of skepticism in our people of color, Blacks and Latinos, on whether or not to even get the vaccine. So we have that, and that's a whole nother conversation of how we can build trust. But then we have the percentage of people of color that would like to get the vaccine. And then we have the social determinants of health that are impacting their ability to get it. The biggest things that I have seen in the ability to get these vaccines is access to the vaccine. They are just now opening up the ability to have transportation, to take individuals, especially those individuals that are 65 and up, or 50 and up, or even individuals that come from a lower socioeconomic place where they cannot drive to these locations or access the locations. Secondly, so much of the access is being given to our communities in high technical places like Facebook, like Google, through apps, and you have to use an email. So if you don't have these things at your fingertips in order to schedule these vaccines, then you're not getting the vaccine. And then we have a lack of the low technology vehicles, such as infomercials, billboards. How about mailers? Those aren't coming out, right? If you don't have cable, you're not going to see how you can get the vaccine down on 78th Street at a park from 10 to 7. So in order to improve that, I think some of the things that we have to do in healthcare is go back to the basics, start calling these people, reaching out to our clinic patients, letting them know that the vaccines are available. Where are they? We may have to do this by phone. Many people have telephones and will answer. The FEMA initiative from the federal government is great, but again, we have to provide access by getting them transportation to get to these sites. Otherwise, if they live in Plant City, it's going to be hard to get to the Greyhound racetrack where they're giving vaccines without proper vehicles.
So if Ms. Nicole was finished, let me just add a little bit to that, because when we start looking at increased infection rates, let's talk about why that occurs. So who is more apt to have multiple generations in their home? Who's more apt to have be in a place where there's multiple dwellings in one space? Who's more apt to take public transportation? Who's more apt to be frontline workers? So some of these things, this is not rocket science. There are clear reasons why systemically people of color are being impacted more. And then we start to look at, and just to another tack on what Ms. Nicole was talking about, is that when you start to look at, okay, so now we're going to put this information out for you to have access to. So we're going to put it in places where you need a car to get to, or we're going to put up pop-ups or different places for you to be able to access. If I can't get there because I'm on a bus system, how do these things work? Now, if you're talking about, okay, we're going to hit the people that are most vulnerable, 70 and up, 65 and up, 55 and up. Am I on Facebook like that? You know, am I accessing these social media platforms in that kind of manner? So when we start to look at this from a systemic perspective, there are clear reasons why this is happening. So I just wanted to put that out there, that there's some other components to consider, and these are all tied to the social determinants of health.
Thank you for that. Yeah, and I would agree. And with that too, I want to bring in sort of Jen's expertise here. And I wanted to ask, what is the role of community-based institutions in helping to level this playing field and increase access for all the populations we're talking about here?
Well, first, thank you so much for the opportunity to serve on this panel. I'm so honored. The points that I want to make are really, in response to the very points that my colleagues on the panel are bringing up with respect to vaccine hesitancy and lack of access. And community-based organizations can play a really critical role from the perspective of, I'll make 4 brief points: acknowledgement, education, access, and collaboration. So the first piece is acknowledgement. We as community-based organization leaders have to acknowledge the reasons for vaccine hesitancy in BIPOC communities. And then given that understanding, we have to understand the importance of providing information that is ethnically relevant, racially informed, and that is sensitive to these factors, and we have to educate ourselves on that so that we're able to go into these education and access opportunities with understanding, how people may come to us. From an education perspective, it is so critical that when we are talking about addressing vaccine hesitancy and trying to get more and more people information that they need, that they trust, should they be able to access the vaccine, we have to make sure that that information is culturally relevant and racially informed. So I hear a lot from my colleagues in the healthcare space that, oh, the CDC is the standard, we need to go by what the CDC says. And that is all well and good, and I do understand that. However, there are many reasons, which my colleagues have already talked about, why Black and Brown communities don't trust the government and don't trust the healthcare system. And so what are other trusted sources that can be created and pushed out into communities that can provide more culturally affirming education? And I know here in Pinellas County, there's now a website called Beat COVID Pinellas that is offering the direct perspectives of Black folks who have accessed the vaccine, who are on their journey of considering the vaccine, and is providing those one-to-one video-based accounts of what that experience is. Also providing information on all the different types of vaccines, doing some myth busting, and then linking back to the CDC. But the lens through which the education begins is one that is more racially informed than if somebody just hops on the CDC website. So as providers in the community-based organization space, we need to be aware of these resources and understand not everybody can access the web, not everybody has a data plan, not everybody's jumping on these websites. And so how can we take information that's out there from sources like this and make it available to the communities that we serve? In terms of beyond education, providing access, this is obviously key. And we play community-based organizations play such a critical role in being able to meet communities where they are. So we operate a health clinic at the free clinic. So that is obviously natural, right? People come into our health clinic. We should be providing the vaccine as it becomes available. Sure. But we also operate one of our county's largest food pantries. And we see, as many as 17 to 20,000 individuals per month that come through the drive-through. We did a flu shot clinic in partnership with Baycare some months ago through that drive-through, where we sent people through the line and they pulled off and were able to get a flu vaccine. And we hope to do something similar with COVID, so that we can provide access for folks who are coming to us for food and can also access that vaccine. I think every community-based organization needs to think about that. If you are a case management organization and you are working with, say, refugee communities, how can you get into that community with a nurse, and deliver the vaccine directly to where people live and work, so that they don't have to, navigate transportation issues, so that we're really doing everything we can, boots on the ground, to increase access. And so it's evaluating, how do we meet people, how do we serve people, and then how do we incorporate the vaccine into that service delivery? I think in short order, hospital systems are going to be looking for partners like community-based organizations to deliver the vaccine, much like they do with the flu vaccine. And we have to make sure we are ready to do that and able to, again, unequivocally provide that access. And then finally, I just want to speak briefly to collaboration. And this is when it's important for organizations to know when to step up and when to step back. So at the free clinic, for example, we may think we know best about so many things, but the truth of the matter is that we're not in communities, that are most adversely affected by the impact of COVID and by lack of access. And I don't look like the community that is most adversely impacted by COVID. It is important for me as a white leader to understand that and to trust the wisdom of communities that are most impacted by this terrible virus, and to listen, and then to take cues from that leadership and to follow the lead of, trusted organizations, say like the Urban League in Pinellas County, that is a big community partner. So what can we do to support our colleagues at the Urban League in terms of vaccine access and delivery? How can we play that supporting role? Listening to community elders, community activists, and truly being willing to collaborate, but also to step back when it's not our role, to be that front runner or to take up space. And I think that understanding how best to collaborate, how to do so respectfully, and in a way that really does continue to promote access is so critical.
Thank you. Thank you. Yes. And when we talk about access and everything that you just mentioned, being something that's really restricting people from being able to have these vaccines equitably, one thing that we also want to talk about in systems is bias. We know that there are also a lot of life-threatening biases in healthcare that continue to put these communities at risk in long-term negative health outcomes, and death as well. So Dr. Wills, being in hospital systems and everything like that, what are some of the specific consequences of things like implicit bias in healthcare, and how does that show up in the overall patient's experience?
Yes, I actually saw one of the viewers in the chat mentioning that a very key one, and that's around pain. There's an implicit bias and the belief that Black people don't feel pain to the same degree. And I actually have a personal testimony around this. This was one time I was having, and I'm a physician, so woke up one morning with acute abdominal pain. And it was diffuse, and then it localized to my right lower quadrant, and I diagnosed myself, and I said, I have appendix, and I carried myself to the emergency room, and I got there, and I waited, and I waited, and I waited, and I waited for pain medicine. Then there was change of shift, new nurse came on, and I said, ma'am, and I clearly by that time I was feeling some type of way. And I said, ma'am, I need some pain medication. I really do. I've been here for 4 or 5 hours. I need some pain medication. So she left, and then the next person that came in the room was a security guard. So rather than give me pain medication, she felt threatened by me, a physician, and I'm in my home community, which is an African-American community that I grew up in. She was a white nurse. So just this idea that we're pain seeking or pain medicine seeking or coming in for pain medicine, and those types of biases play out. Now, when you ask folks in healthcare are altruistic. Folks in healthcare want to help people. None of them believe by any stretch of the imagination that they could be contributing to the disparities and outcomes that we see. And so they don't really check themselves on those kind of things. I mean, they think they're right by bringing security guards into the room. Another area where that comes into play is just with Black children. And the fact that Black children are seen as less innocent, right? And so if things are happening in Black households with Black children, they're more likely to be placed in boarding homes as opposed to therapeutic foster settings, or disciplinary institutions as opposed to a home where a family could take care of them. So these types of decisions are being made and triaged at that individual patient interaction level every single time. And then you wonder and you step back and you say, well, why is it that Blacks die of heart attacks at a more likely rate? Why is it that we die of cancer at a more likely rate? Why is it that infant mortality in Black communities are 2 and 3 times higher than in white communities? It's because these interactions and these standards of care are not being delivered at that patient, clinician interaction level for whatever reason. And until we shine that mirror and that light up to folks and say, everyone has a responsibility in this. And I want to go back to something that Ms. Williams said earlier that I thought was quite compelling, and that is that the institutions have defined racism in and of itself as a risk factor, as a health disparity risk factor. One of the things that we have to remember is that life expectancy for African Americans, and by that I mean Black Americans who were descendants of slaves that were brought to the United States mainland, have a shorter life expectancy than Caribbean Americans who are Black Americans. And so we think, what is that disparity? That disparity, and we've got access to better technology. We've got access to more fancy hospital modalities. We've got access to all the information and all that, but yet we live shorter lives. And so what is that? In my opinion, I think that's in large part due to institutional racism as well as implicit bias that happens in the exam room. And so until we start to have valid conversations about these things for all people, and that's why personally I don't like the term ally, because I don't think that people who are not people of color need to be allies. They need to be advocates. They need to be learning themselves too. We aren't the only people who need to be jumping up and down about this. Everybody needs to be understanding it. It's their responsibility. It's their system. It's all of our system to create, but to change. But everybody, we can't be the only one just fighting and say, oh, good, you're a friend. You're a friend, you're an ally. No, you got to be advocates too. And there need to be healthy conversations in mixed spaces. And I appreciate the fact that we have mixed spaces in here about how to deconstruct some of this so that people can shine a mirror up to themselves and say, how do I, when I'm in that exam room, have that interaction where I'm listening and hearing and not fearful and not afraid and those sorts of things. So it can be dangerous. I said one of our viewers put that in there, life-threatening, dangerous. It's very, very real. So those are some of the ways that bias plays out in the exam room and turns into structural racism.
And as we're talking about that, I just wanted to kind of throw out this question to everybody, but what kind of specific tools can we use to bring this to the light? And what kind of specific tools are available for healthcare providers to begin to address these biases in their space? And before y'all go ahead and answer that, I also want to ask the audience a question. Just keep posting in the chat, but what is sticking out to you from this conversation, and how is knowing this history and what we're talking about helping to shape a better future in healthcare for diverse patients? So as the audience is answering that in the chat, anybody could feel free to chime in for that point.
I would like to say, Erica, that the best way to start addressing it is education. We have to educate our healthcare professionals in schools, but then we have to also continue that education into the profession. Cultural competency is huge. Understanding that we all have implicit bias is huge. Figuring out what that implicit bias is quintessential to being able to tackle it. There's the Harvard implicit bias test that you can take for free to get an understanding of what your biases is, because we all have them. We have to understand that without the education and recurrent education of our professionals, we're going to continue lacking cultural competency, not only for African American communities, but for all communities that don't look like you or me. We have to understand how do we speak to an Israeli woman? Do we speak to her alone, or do we have to speak with her spouse? How do I speak with the Hispanic woman to get her to understand and then trust me? How do I speak to a fellow African American sister? It's very different for each of those groups, and in order to do that, we have to be educated. I think a big point that Dr. Wells made that I want to second, for lack of a better word, is that biases are weaponized. So if we think of a bias, we need to think of weapons. They are intended to destroy. And when you think of bias, you think of improper or insufficient treatment and care, because you're already making an opinion about how you should treat that patient, and it doesn't necessarily mean that you're giving them the most efficacious way of treatment or the most sound treatment, because you're impaired. And that is serious, and it kills people, and it has killed people, and it's one of many reasons why people of color don't trust government and why we don't trust the healthcare system.
I think that is an excellent point, and I see Kimberly wants to chime in as well.
Thank you so much. I just would like to add on to what you were saying, Nicole. I mean, I think when we started education, and then we move on to now acknowledging and accepting that the bias is there, right? That it exists, that we have it, we are all guilty of it, and just trying to have those very difficult conversations. I'm talking about from the top down in our organizations. I use the example at Advent Health where we were, I will say, strongly encouraged to just sit down with one another and start having these tough conversations, and sharing our experiences. You know, I remember sitting in the office with my boss and sharing some experiences with him, and his tears came down his eyes, you know. And you know, of course, it's difficult to have these conversations and to be transparent and to take down this wall of protection that we all have in our workspaces, because it's not easy to talk about the realities of what we deal with every day, even right there in the C-suite, in with our coworkers. Dr. Wills, I'm pretty sure you've been in moments where you're like, this happened because of who I am and what I look like, you know. And so I think having those tough conversations is not easy, but it's something that we have to do with people that don't look like us, with people who don't, you know, have the, you know, do everything that we do. But it's sitting down and saying, okay, let's talk about this, because it's uncomfortable, but it opens the door for us to really say, how do I make a change, and understand where the error of my ways are, because we all have some sort of implicit, you know, bias that exists. But if we never admit to that and acknowledge that, how do we take the education now and take that as a bridge to actually finding solutions? And you know, won't happen overnight, but it's a start. So those are my thoughts on that.
And white people have to be willing to have these conversations. You know, leaders, healthcare providers, advocates who look like me have to understand the persistent day-to-day reality of systemic racism, we, you know, in healthcare, in all of our systems, and how we are complicit in upholding that. You know, whether, I mean, that's uncomfortable for white folks, but, you know, we have to grapple with our privilege. We have to grapple with the way that the healthcare system privileges the experience of white patients, the perspective of white patients, white providers. And so how do we absorb that and get into these uncomfortable conversations, be willing to listen to feedback? But it's so critical that it is not just about showing up for the conversation and listening, but how do we commit ourselves then to action, right? Because once we know better, then we have to do better. And so it is imperative. It's, you know, folks who look like me that uphold these systems of oppression. And so it's folks who look like me that have an enormous role in dismantling it. And I think that, you know, as we've talked about, I mean, racism is quite literally killing Black people. And if we don't address that at the root cause, and that comes, you know, from white people needing to address our own, you know, racist ideals and practices and all of the ways that show up in our systems, we don't get anywhere beyond having a hard conversation and then just moving right along and not really changing anything.
So an additional point to consider, and I totally agree with all of my colleagues here, and as the brother on the panel, some of it also, it's about being supportive of each other. If you know someone is falling down a little bit, to reach out to them and give them that level of support. So speaking from Black men, we don't go to the doctor. For what? You know, my doctor is my wife. My doctor is my girlfriend. If something wrong with her, then I know I got an issue and now I need to go to the doctor. Or something is so painful that might be at the point of no return is when I decide to engage, because I don't really have a choice. And at that point, I'm probably being dragged to the hospital because I can't bring myself there anyway. So part of this is having the regular routine of just getting regular work done so you understand where you are. Part of that is education, but part of that is fear. I don't want to know. I don't want to know what the issue is. People think that I'm Superman, so let me just go ahead and do that and I'll be good. So part of this is also looking out for each other. And Dr. Wells, I appreciate the idea of an ally. And we actually, in the work that I do, we take it a step further. And as strong as the word is advocate, we use the word accomplice. And I know it has a negative connotation to it, but the idea, when you look at the Latin root word accomplice, it means I am attached at your hip. If you go down, I go down. So as an accomplice to each other, as an accomplice in this work, it's no longer about being an ally. An ally can opt in or out. An accomplice, I'm in there, I'm rocking with you no matter what. So the idea of this simply is, how do we create a space and place for us to be able to engage in this conversation honestly, realistically, but with the understanding that this is going to require incremental progress, but steady pressure and a level of intentionality. So white folks, white colleagues, it's time to engage. the idea of this now becoming a thing because of George Floyd, Breonna Taylor, that news is not saying that it's old, but seriously, it's not like you didn't know this was an issue before. And now to engage, okay, now you saw it for 8 minutes and 46 seconds. Now you saw that, so you can't unsee it. So now it's time to come together, have the difficult conversations. Yes, they're going to be courageous. Yes, they're going to be uncomfortable. We've already ripped off the Band-Aid. Let's do the healing part of it, which is cleaning out that nasty infection and putting on some real new bandages that allow us to heal together as a community. But now it's time to have a conversation so we can collectively move this needle and save some lives.
And they're not easy conversations. They absolutely, positively are not easy conversations. And the power of racism, right, is in the silence, right? So not breaking that ice. And I have mixed feelings about it because I actually saw someone talk about this not too long ago where, I've been sort of, we've all been kind of ducking and weaving and trying not to talk about race for a long time. And now here we are having to expose these very, very vulnerable aspects of our lives. And, whoever, I was about to make an bias, your friend comes and says, hey, well, what is it like? When you're like, wait a minute, back off, I'm not ready for this. So it's hard. It's hard to lean into that discomfort. And it may be sort of just a quick question for them, but it's your whole life for you. It's all 48 years, every minute of every 48 years of your life that you're guarding against and trying to understand and make sure you understand the other, even though the other kind of ducks their head in the sand and acts like they don't understand what's going on for you. I agree with you. People act like, oh my gosh, this is happening. No, we are well aware that this has been happening all of our lives. It's just now other people are choosing to see more of it at this time. And so I think it's a good moment. It's a good life moment to get some action, but I agree we've got to move forward and lean into the work.
And as we're having these conversations, I just want to have a dear white folks moment. Please don't get upset if we're not really responsive. The level of fatigue that we're having right now in these conversations is inordinate. We're at a precipice in this conversation that's probably at its highest point that has been maybe even in history. Not really sure. But the idea of it is that just please understand that we're having this conversation every single day, multiple times. So you might be the 500th person that we've had this conversation with in a month. And it might be just that tipping point that we're like, you know what? I don't really want to talk about this right now. So please don't take that as a sense that we're not engaged, that we don't want to talk to you. It's just that it's a level of fatigue associated with this conversation just because it's at the top of everyone's mind right now.
And as we talk about fatigue, I think one thing to really bring up that we had talked about as well is just this engagement with media right now. People tend to trust and put their resources and energy towards those resources that they're comfortable with consuming. We have access to so much information on social media, the news, and so on. So how do we address that in building trust with communities of color?
That's a really good question. And it's one that's really hard to tackle. I mean, I think that's with fake news and everything else and everything that's going on. I'm trying to figure out who do you trust? I mean, do you trust Cardi B? Do you trust, I see, seriously though, I mean, is that the right spokesperson? Do you trust LeBron? Do you trust, who's going to be able to be a good is it Oprah? Is it Michelle? I mean, who's going to be a good spokesperson that's going to activate folks and inspire folks to action? I mean, is it going to be me as a Black doctor? Is it going to be us on this panel? I don't know. Maybe, maybe not. For some people, yes. For some people, no. But we're all getting our messages from so many places right now, and we're all in our information silos that it makes it hard to really figure out, who's going to be able to give the credible message, to be able to say, and this is true. I got my second shot today. And I'm feeling good. I was kind of worried. I was like, oh no, this is a shot where you get the immune response. Am I going to be okay for this panel tonight? And I am. I'm still standing. And but I know a lot of people have fears, and I respect those fears. I really do. Like you said, people are on their journey to vaccination. We've got to be comfortable helping people along that journey and giving information, sharing what we know about the vaccine, and so that people do feel more comfortable being a part of the solution of getting rid of or learning how to coexist with this virus in ways that we've gotten over other public health issues such as measles, mumps, rubella, polio, HIV, all of those other epidemics and pandemics that we've been able to really fight as a society collectively when we all kind of work together.
Oh, sorry, I was on mute. Yes, I agree. That's a wonderful point. And with that, I wanted to know as well, how can health system leaders, service providers, and community organizations create these safe spaces for diverse patients, Eric? How do they provide that access to quality care and support in terms of long-term health outcomes?
So, I mean, I think that's really based upon a lot of the conversation that we've had around education. But I'm going to take a slightly different tack in terms of it's time to recognize where we are and what's happening in the medical community. Cultural competence was born out of the medical humanities. This is not a foreign concept. It's not a foreign concept at all. And so to have a bedside manner, so to speak, that's counterproductive, that's steeped in isms, whether that's racism, sexism, or anything else, is really counterproductive to the conversation. I can tell from a personal perspective, and if you have met me, I'm a shorter dude that's wide and powerful looking and all that good stuff. But when it comes to going into a doctor's office, I white coat like nobody's business. They're like, "Why is your blood pressure 170 over like 82?" It's like, because I don't want to be here. I don't like y'all. I don't trust y'all. And when I come here, I feel like I'm being penalized for existing. So when I'm at home, everything is normal. So the idea of going to the doctor becomes a major thing for me. Because I don't ever go there and get good news. It feels like it's some kind of judgment in terms of what I've done, what I've not done. And, I've definitely shot the messenger a number of times when I got the blood work. I use that conversation all the time in my own work in terms, how do you move the needle and stop shooting the messenger, but understanding the information. The challenge with it is that as a physician, you have to see how many patients in the course of a day. So you may get 10 or 15 minutes of quality time per patient, and you got to move. That becomes challenging if you're trying to understand what does all of this stuff mean. Additionally, and I'm going a little bit off track in terms of the answering the question, but I'll come back, trust me, is that when you don't have enough of us participating in medical trials, so to understand how medicine impacts us as a group of people, our DNA is different than white folks. So when you have all of these trials and you have these medications that are specific for different issues, some of the things that I've asked in navigating blood pressure and things like that, I'm like, how does this impact someone that looks like me? And I get the inevitable, well, what do you mean? I said, I'm a black man. And this medication, how does it impact black people compared to white people? Rarely do I get an answer. They may pull out that big, huge, y'all know I'm talking about, that big, huge blue book that they got to go sift through and try to figure out what exactly I'm talking about based upon the medication that I have. So, and I feel like a lot of it is trial and error. Well, let's try this and see what happens. Oh, you had a reaction. Let's try something else. So the thing about this is that what's helpful, understand who your patients are. That was the whole point of cultural competence, was to understand, okay, if we're going to have a hard time diagnosing poor people and people of color, we need to do a better job so we can stop getting sued so much. So the idea of it is understand who your patient is. If I've walked into your office 15 times, you know I'm a black man, almost 50, you should know a little bit of something about me, so that we can have the kind of conversation that even in that 10 or 15 minutes is going to be impactful. Part of that is understanding who I am and looking at me from a point of equity. I know who you are, Eric Smith. I know you're my patient. So I know that you have these certain proclivities. I know you have these certain tendencies. So let's talk about that. And what does that mean? As opposed to one size fits all, we're going to get you in and out. And I'm not really sure if I even care about what your issues are. Take this medication because you're not going to do the work that we want you to do anyway. So take this medication and this will hopefully prevent you from dying. It's not a good recipe for having a supportive healthcare system that's going to allow you to move the needle.
Thank you, Eric. Thank you. And all excellent points. I wanted to point this next question towards everybody as well, because we're getting some audience questions. How has white privilege shaped healthcare both from an internal and external way? That comes from Miss Angelique.
Thank you, Erica. So I think that question I've seen it in the chat a couple of times, and it's really important. So white privilege has shaped healthcare in the amount of color that you see in your providers. It also has shaped healthcare in the way of access to care, access to certain testing, access to certain treatments, sometimes aren't offered to people of color because there's assumptions made that they can't afford it, they won't comply, they don't care anyways, they're just going to keep doing what they're doing. So sometimes when you have certain conditions, there can be one great treatment plan, but it's not offered to people of color. We've seen that. We've seen that with COVID. Personally, I had an aunt that died from COVID in early May. And I can tell you that she was in a hospital, and I had a friend whose father was in a hospital here in Florida, 2 different states, but 2 different colors. And he was offered a lot of different treatments. And when we asked them about the treatments for my aunt, we were told things like, oh, it's experimental. She has to be put into a blind study, and then we'll see which one she gets. Maybe she'll get the placebo, maybe she won't. But here, he was given all kinds of antivirals, all kinds of things that made him better. And he survived. And I watched my aunt die in 14 days because she was put into his trial. And it didn't work. And we can say that that was a state thing, and maybe it was. But what I can say is that she wasn't given the same access that had she been maybe our white counterpart, who was 68 years old, with a very, minimal past medical history. Maybe if she didn't have mental illness, she maybe would have been treated differently. So when we talk about how white privilege affects us, it affects us from the very entrance into the healthcare. Eric expressed his concerns about how he would be treated as a Black male because of how he has been treated as a Black male. Going into his doctor's office. One thing I'll say is, please, brothers and sisters, find you a provider that you trust. Find you a provider that maybe looks like you, that maybe is in your community, that maybe you're getting recommendations from colleagues and friends, that maybe has more than 15 minutes, because the foundation of primary care, which is what I do every day, is to build relationships and to build trust with my clients. If I don't do that, I'm not going to get them to take a pill. No matter how much I explain how much the pill, how it works for you, how it works for you as a Black person, how it works for you as a woman, they're not going to take it if they don't trust me. So you have to take the extra 5 minutes, the extra 10 minutes. It matters to help and build trust and build respect and mutual understanding between the clients, because that's going to help break down the barriers of white privilege. Because when they walk out of that office, they're going to feel like they matter, instead of feeling like they're just another number and you have providers.
And I see Kimberly has some input as well, and I wanted to kind of address that. And I think, Kimberly, you can answer this too, with what you were going to follow up with. But we have a YouTube question as well from Miss Lorena Fernandez. That says, what are ways that we can protect ourselves as people of color against bias in hospital settings? I feel like we were talking about a lot of that individual experience when listening to Nicole. So I was wondering if you could also provide your input to that question.
Yeah, I've got some thoughts on that. If I could jump in, one thing that you can do is just ask questions. Ask good questions of your providers. And just say, hey, I'd love to hear your thoughts on what it means to provide culturally affirming care. How many persons of color do you treat and do you not treat? And just ask those questions. I mean, it's fair game. Just as you're asking about a diagnosis, that's part of the therapeutic interaction, and asking those questions is fair. And if there are answers that aren't satisfactory, then try to find other providers. I think also taking a step back, we got to do a lot more pipelining around creating a pipeline of talent for young folks of color to pursue careers in medicine. I know there are certain schools historically who have done a great job of preparing at the undergraduate level. I think of Xavier University, I think of Howard University, nurses and physicians and dentists and all of that go out and serve communities of color, oftentimes getting paid lower rates because they're making that commitment to underserved communities. And so finding physicians of color who are able to relate in that way better with their patients or their clients. So those are some things that I think are good ways of taking that step for yourself and advocating for yourself, just the same way you might look up a diagnosis beforehand so that you can understand what's going on. Those are other things that you can do as well.
Yeah, and another thing to Dr. Will's point is, I saw in the chat, you don't go alone. Don't go to the hospital alone. Because when you're sick, sometimes you're not your best advocate because you're in pain or you're not as awake and alert as you would be if you weren't dealing with whatever illness you're dealing with. So, it's hard now in COVID, but more hospitals are allowing at least one person to go with you to the hospital, especially if you're not going to a COVID part of that hospital. So take advantage of that. Don't go alone. If you have the ability of technology, bring in that FaceTime call to your support team so that they can be in the exam room with you and your doctor. The other thing I always tell my patients so that they don't leave without having all their questions answered is before your appointment in the outpatient setting, take time to write down your points. Take time to write down those questions that you want to ask your doctor or your provider so that you don't forget, because just as Eric said, when he walks into the doctor's office, he gets white coat. So white coat isn't only your blood pressure going up. A lot of times it's forgetting everything. It's forgetting every question that you had. You don't remember. You walk out of there, oh, I meant to ask about cholesterol. How's that going to affect me? Oh, I meant to do this. You forget so much because you're afraid. You develop anxiety. You're in a place where you don't know people or you don't trust, or you're worried about how they're perceiving you or judging you. So writing your questions down ahead of time and not going alone is going to ensure that you advocate for yourself, that you're intentional with your care, and it changes the conversation a little bit with your provider, because then they also understand that, oh, they're knowledgeable. Here, let me share more information. Now we can have more of a conversation than me trying to educate you because I'm understanding where you are and I can meet you where you are easier and quicker.
So Erica, just real quick, something else to consider is leveraging your relationships. And in times of advocating for yourself when that's not possible, what I had to realize is that I wanted a second opinion. So I happened to find a friend of mine from college that's a family physician. And I send her my labs every single time I get it. And usually, like 85% of the time, she's right in line with my primary. But sometimes she says, ask her this, ask her that, ask her the other, because I don't know. But this is also someone that I can't use as a doctor, but also cares enough about me to give me an honest opinion, leveraging her medical expertise. So sometimes it may be helpful if you have a friend that's a nurse practitioner, or a friend of a friend that's a doctor. Can I just take 5 minutes to have a conversation? I don't understand something like this. And they may or may not be willing to have that conversation, but the idea of it is look for additional people that may be able to offer a second opinion. One last thing, do not get your diagnosis from Dr. Google. One more time, do not get your diagnosis from Dr. Google. All right, I'm just gonna leave that right there.
Thank you for that. Now, we are going to have to.
Can I jump in?
Go ahead, Kimberly.
Holding on to it, but I was gonna let it go. But I just wanted to add another piece to this puzzle is making sure that we do have enough minority representation in the fields of medicine, right? So it reaches back to kind of connecting to what Nicole said earlier, reaching back to even before we get to the part where we're searching for a provider that looks like us, right? That we can relate to and we can trust. We as we have to figure out ways to make sure that pipeline is there for our minority students to have resources to study for the MCAT, to have those resources in place that they can be accepted into these medical programs and be mentored. So it's kind of like we need to reach back and see what can we do. If it's mentorship, is it is it connecting with schools and finding ways to support, getting our institutions to pour back into organizations that are supporting the education of underrepresented minorities, because that is also a strategy to making sure that we do have enough representation in the medical field: nurses, physicians, doctors, nurse practitioners, researchers. We need researchers that look like us so that we are now a part of that conversation, right? And want to trust actually going in and being a part of these clinical trials. So it starts there. It's rooted in, how do we make sure that we have enough folks in the medical field that we can go to and trust and look up on Google and research them and make sure I like that physician, right? Or, so those are also strategies to make sure that we have representation in the field, in the field, so that we have access to people who look like us that we trust. So that's just another strategy to overcoming the white privilege piece of having that education access. We've got to make education access for underrepresented minorities as well.
Thank you. And I think we'll have to close out tonight with some final thoughts. And this last question from Lakeisha in the audience is, what are your thoughts about the best way to incorporate cultural competence into research so that more people of color can be involved in clinical trials and address this mistrust? How important is that? What are your final thoughts closing tonight? An audience engagement question as well. As we're answering these final questions, we want to know what your concerns, if any, are about the COVID-19 vaccine, just to keep the conversation flowing. Any panelists can feel free to answer that last question.
So happy to jump in here. Like I said, I did read the research on the COVID vaccines. And for me and my family, we decided that it was a good move. And so today I got my second shot. So that's my feeling there on the vaccine as a physician and as a physician who went to the primary literature. And I would recommend it for those who are considering it, but do understand if there's hesitancy, and happy to talk to folks about it that are in my circle. So in terms of sort of final words, we've got a long way to go, a lot of work. But I think kudos to Tampa Bay Spark for hosting conversations like this one to get folks interested and having good conversations and listening and learning. These are hard conversations to have, very hard conversations to have. But I think unless we don't all come together and talk about these things, we're not going to come up with solutions. Racism is real. Racism is real in medicine. And the only way that we're going to be able to unpack it is to continue to have dialogue such as this, and also continue to create that next generation of African American, Hispanic, Latino, and Indigenous people who are serving in various health capacity caretaking roles. So I think those would be my final thoughts.
So
I would say that, I'm sorry, Eric, you want to go? To answer Lakeisha Cousins' question, I think that is going to be difficult because it's going to start with educating our communities of color about clinical trials again, because they have been hurt really hurt from clinical trials. So to take away that mistrust is going to start with education, and then it's going to start with intentional, active work in the community to foster trust. And that means that we go out to the community. We realize that racism is a public health problem, and we start to have community events, community fairs, community activities with not just small community organizations, but we begin to go to Jen's point of collaboration. We can collaborate with some of our larger companies that have deep pockets, to where we can start to educate and then intentionally become a part of the community in a way to build that trust, so that when it becomes about a clinical trial on cultural competency or demystifying biases, now you have more people of color that are going to be willing to join them and have their point of view heard and be part of that data. And it's going to take time. It is not going to happen today, but today can be the beginning. And we can start here and intentionally work to build these communities and to build these relationships. And then I think when we look forward in 10 years and we're educating new nurses and new physicians, then we can have this data as part of their study, so that we can build more culturally competent and aware providers to provide better care, not only to African Americans, but to all people of color.
So in terms of the vaccine, I've gotten mine, and really for my children. Both of my children are immunocompromised, and it was the recommendation of their doctor that I get myself vaccinated, but I probably would not have, nor would I have taken a flu shot, because I never have. But for the people that I love, I took care of them through me. And I think that's another part of this, is looking beside yourself, and that in some cases, not looking at the vaccine, not doing the research is pretty selfish. Especially when you can protect yourself, your family, and the people that you really care about. So those are just some things to consider. In terms of cultural competence, you always have the ability to hold your physician accountable. Ask the questions. Like, hey, the next time we talk, can we talk about this? Request that information so that they know when you walk in the door, they need to have their A game together. Or you always have the ability to find another physician. And they're not going to want to lose business or lose you. So think about it from those perspectives, and that you are actually in the pole position for your health, and you have to be the curator of your own health. Also want to give a quick shout out, Kimberly, move to the cues. Okay.
I'll jump in after that. Thank you for the shout out. I think that, just so you know, I also got my vaccination. I'll be getting my second one next week, and I'll be catching up to you, Dr. Will. So hopefully I will also feel well. But I will say that, just to add to that, doing it for the people that you love, right? The people you love. I think about my grandmother. She hasn't been able to travel down to Tampa to see me for it's been a year. Can you imagine? And it's because we want to keep her safe, right? I want to keep her safe. But making the decisions for those you love, and I appreciate how Eric just kind of put that together. Kind of to add on to what Nicole mentioned about the collaborations and being intentional, I think it's really important to go in and with our collaborations and not go in with all the answers, and not go in and say, we know how to solve all the problems, and we're going to tell you how to get over your mistrust of us, right? Of this system. It's going in and saying, I'm here to listen first, to have empathy, to understand, to see how can I first establish a real true partnership that does foster trust, instead of coming in with all the answers and saying, I got this, I'm gonna tell you this is how you're gonna get over your mistrust. So I think being intentional with those partnerships and those collaborations, and getting non-traditional partners involved in those connections in the community, because it's gonna take those non-standard partnerships that, the ones you're used to going to all the time and hanging out with. No, we've got to make this bigger if we're going to solve this problem and work together. So just being intentional and not going in and saying, I got all the answers, but going in and being listening to the community and saying, how do we do this together? Because we got a long way to go. Just like Nicole mentioned, we've got a long way to go.
Erica, I didn't know that we were to talk about the COVID vaccine, so I just wanted to comment on that.
Mm-hmm.
I definitely support getting the COVID vaccine. I've been vaccinated since January. I think that when we talk about taking this virus and bringing it to its knees, it's going to require a lot of us to get vaccinated. And it's not going to be 100%. That would be way too fictitious of an optimism to have. But I think that if the majority of us become vaccinated, it'll be less infection that we can have. And I was reading data from Israel where they started vaccinating people at a much more efficient rate than the U.S. did, and it decreased the infection rate of COVID to 12%. So that is with the variant that we've been seeing develop since the virus started in 2020. So I would say definitely educate yourself. Ask your primary care provider if you have questions about the vaccine, even if you think that they're crazy. I had a question today, did the vaccine cure cancer? So no matter what the question is, ask your primary care provider. And then I hope you can find a primary care provider that you have trust with, that you can believe what they say and hold what they say as true, because that's going to help you vaccinate yourself. And as we vaccinate ourselves, we're protecting not only us, but just as Kimberly said, we're going to protect her grandmother so that she can visit her grandmother. And I just can't wait till my children that are 18 and 20 can get vaccinated, because I will be a lot less cautious about their health when I know that they're protected. So I can't wait till the age limit just keeps going down until they can vaccinate those healthier individuals that are young. Thank you.
Great. Thank you for all these great thoughts. And I'm also on track to receiving my second vaccine as well. As a public health professional, I feel like it's definitely the responsible thing to do. So thank you. And I just wanted to say that this has been such a rich conversation tonight. We are receiving lots of great feedback from all of our audience saying thank you, panelists, for such a rich conversation. If we have no more final thoughts, I wanted to turn it back over to Tammy to close us out for the night. Tammy, who is on mute.
I'm on mute. Like the number one thing that people say nowadays, you're on mute. First of all, can we all just give a virtual round of applause? If you're watching, just kind of like clap your hands. We'll feel the energy. We'll feel it. Erica, thank you so much for moderating this amazing conversation. Kimberly, Nicole, Dr. Marquita Wills, Eric, Jen, thank you so much. You've talked about so many different aspects of bias in healthcare. I mean, I feel like we went through a whole textbook worth of information. So thank you for not only educating us from a systems level, but you also educated all of us from a personal level. I will tell you, when I go to the doctor, I have my questions written out as well, because it's very, very important. We have to advocate for ourselves so we feel extremely equipped. And not only that, we feel inspired, and we all play a role. All of us, for those of you who are in the audience, you play a role in advocating for your own health and the health of others. And I hope that after this conversation, you just got a couple of nuggets of wisdom. So thank you again to our incredible panelists and our moderator for really leading us in this important conversation. Now, I just want to share a couple of updates for Spark as we close. Definitely follow the speakers. We've been sharing their information throughout the presentation. So you want to just go back real quick, rewind, write their names down, follow them. They're incredible leaders in our community. And also follow Tampa Bay Spark on LinkedIn, Twitter, social media. We have our next upcoming event on April 29th, where we're going to kind of go into the conversation of economic justice. And we want you all to be a part of that important conversation. How do we not only talk about justice, but how do we invest in closing the gap in our different communities. So we're very, very excited to host these incredible conversations. Go to our website, www.tampabayspark.com, to learn more about our work. If you're interested in joining our incredible team, if you're interested in being part of what we do, we would love to hear more from you. Follow us, and we look forward to hearing from you all soon. Have a wonderful night. Thank you for watching us. Thank you for joining and engaging with us, and we'll see you soon. Thank you, everyone. Bye.